Professor Khurshid to kindly come. Thank you.
This is a kind introduction. First of all, my heartiest congratulations to Pakistan Society of Internal Medicine to arrange such a marvelous symposium during this COVID time and covering very important topics in medicine. I congratulate the President PSIM, Professor Javed Akram, for his leadership. Javed साहब मेरे उस्ताद भी हैं, मेंटर भी हैं, कुलीग भी रहे, फिर हमने इकट्ठे काम भी किया और एसोसिएट्स भी रहे और अब मेरे बड़े भाइयों की तरह हैं. तो अल्हम्दुलिल्लाह, I always feel honored and privileged when I'm around him. And thank you very much for inviting me to talk on this very important issue, which is very near and dear to my heart. We just recently published, for those of you who are looking into this topic in more detail, from the platform of Pakistan Endocrine Society, we published guidelines on metabolic syndrome in Journal of Pakistan Medical Association, APMA, in 2020, and then very recently, 3 months, maybe 2 months ago, we published guidelines on metabolic as well. Are at high risk for cardiovascular disease, cerebrovascular accidents, peripheral vascular disease. So there's something more to it. There's something more to it than just the hyperglycemia which causes all these problems. So that's when the term of metabolic syndrome was coined to lump these factors together. And the purpose of putting these 3 or 4 features together in metabolic syndrome is to address the cardiovascular disease, cerebrovascular accidents, and other complications associated with these metabolic disorders. So I think very briefly I will go through these slides. I know I have only 25 minutes, so we'll talk about diabetes, metabolic syndrome, metabicity, and what can we do to handle that. Because at the end of the day, the most important question is how we can prevent these things. Medicine, from treatment part, the rest of the world is moving towards the preventive part. So treatment is always very important, but the prevention is the foremost thing, and we'll have a brief talk on that as well. So this is the curve. If you see the number of diabetics worldwide from age 20 to 79 years of age, you just look at this figure. The numbers are astounding. It continues to go up, and there is no stopping here. Yeah, I put this slide, which is not the most recent slide. This was only about 2 to 3 years old, but there's a reason I put this slide, which is a bit old, 2 to 3 years. If you look at this slide, the number of patients with diabetes in 2017, so about 4 years old slide, in Pakistan was 7.5 million. And prediction at that time in Pakistan was we will have, in 2045, we'll have 16 million patients with diabetes in Pakistan between the age of 20 to 79 years of age. Can anyone guess what are the number of diabetics in Pakistan right now? Any guess, any estimates? How many diabetics in Pakistan?
20%.
About, in terms of absolute numbers, if I say, talk about absolute numbers, so IDF was in 2020 came out, we said there are 19.1 million patients who have diabetes in Pakistan, based on IDF data, which I think is underreporting. But look at this, I mean, just a few years ago we were saying in 2045 we will have only 16 million, but we are in 21, and the 2020 data showed us there are 19.1 million population already diabetic there. So it's very alarming, it's dangerous, because we are into this epidemic in such a bad way that there is no stopping. We are falling under our own weight. So is diabetes as well. So just to show you our in coming years, there are projections from all organizations and all societies, but all those projections, we overtake them so quickly in fewer number of years, which is quite alarming. And these numbers are underreported because two of the biggest studies which have been published in Pakistan. They are through Bakai Institute of Diabetes and Endocrinology with Professor Abdul Basit. I saw him this morning, I don't know if he's here or not, that from his center. The second biggest study which was done through Pakistan Endocrine Society was from Hyderabad Medical Complex by A.H. Amar and their group. In those studies, in one study, the prevalence of diabetes in Pakistan was about 26%, in other it came about 17%, but even if you take the average between those two, our percentage of diabetic patients between 20 to 79 years is somewhere above 20 to 25%. So that means 1 in every 4 or 1 in every 5 individual is diabetic. And we believe for every diabetic patient, there are 2 pre-diabetic patients in the population, in public as well. And this is what is very concerning. If look at we fall in this MENA region, which Professor Usman Sheikh, he worked very hard to make collaborative efforts to do all the numbers and figures for the MENA and IDF region. So that's the region we fall. This is MENA and IDF region. And in this part of the world, the number is increasing by 84%. Compared this to the rest of the world, in USA, 35%. In Europe, it's only 16% increase. So it's just a sad state of affair. The purpose of showing you these slides is for our economic indicators, we never even get close to those indicators. But when it comes to these morbidity kind of indicators, mortality kind of indicators, unfortunately, we overwhelmingly take over these numbers in much shorter time span. While it worries so much about diabetes, it's a leading cause of blindness, leading cause of end-stage renal disease. 50% of all non-traumatic amputations happen because of this. 2 to 3 times the risk for cardiovascular and cerebrovascular disease with diabetes there. So when I say diabetes, obviously these days we like to talk more in terms of metabolic syndrome, metabolic disease and metabolic syndrome there. So someone who has diabetes is just a nightmare, because in these patients it's not only the hyperglycemia which is the problem, but coupled with this hyperglycemia, these patients have dyslipidemia, and we all know that increases the risk for atherosclerotic cardiovascular disease. These patients are hypertensive as well. These patients have endothelial dysfunction. One of the biggest problems these patients have going on, which we tend to underestimate, is increased inflammatory markers and increased endothelial dysfunction in these patients. These patients are prothrombotic, at high risk for thromboembolism, and low-grade inflammation is going on within the organ system, within the tissues, within the cells of these patients, unfortunately. So it's just not the diabetes, it's this deadly quartet, which is very alarming, very dangerous, consisting of central adiposity. That is the main risk where these problems stem from. Diabetes or dysglycemia, you can say this, hypertension, and dyslipidemia as well. So it's a deadly portrait of all these things, and the root cause of this problem is this central adiposity. This is the fat around the belly area. If you look at the imaging of these patients, there's a lot of fat stuck within the visceral organs there. The fat which was supposed to act as a supporting cushion for these cells, was supposed to provide nutrition, but too much excess of anything is too bad, and too much visceral fat produces all those cytokines, chemokines, and triggers all this endothelial dysfunction, generates all those reactive oxygen species to cause this problem. So this is the slide which applies to the Caucasian population. It's kind of a busy slide, but the risk factors I already showed you what apply to this population. Adiposity there, these numbers, let me show you. For Pakistani population, the men waist circumference, which is 35.5 inches. Now think of all of us sitting here, and I would ask you to go home and check your abdominal girth and see what it is. 35.5 centimeters for males, 31.5 centimeters for females. That puts you in risk category for metabolic syndrome with central adiposity. Triglyceride of more than 50, HDL of less than 40, blood pressure of less than more than 130 by 85, or fasting glucose more than 100. Any of these 3 factors you have out of these 5, you have metabolic syndrome. And the root cause, the underlying problem in here is this central adiposity, and why we are getting fatter than what our previous generation was. Because a common question which is asked all the time is, our ancestors, we say we have thrifty genes, we don't have good genetics for, as far as the metabolic disorders are concerned, but our ancestors also had the same thing. So what kind of environmental factors came in to trigger all this? And there are two big campaigns going on right now. We are doing diabetes prevention campaign from the platform of Pakistan Endocrine Society, and my mentor, Professor Javesa, my brother, he is running a very novel program as well on diabetes prevention, which is, and Professor Zaman Sheikh heads that program, which is prevention of diabetes by looking into the genetic and environmental factors and how to address those. So it's like a two-pronged approach in these patients, not only to pin down what is causing these problems, but also at the same time address how we can handle those problems. So in coming months and years, hopefully months, we will see the fruit of all this. We will see in paper format publication coming up with that as well. So the overweight, obesity, there's a lot of numbers. I'm not going to take you through this busy slide, but this adiposity is the biggest problem for our Asian population. The numbers are much lower, like earlier I said. Here are the numbers for our Asian population. This excuse my titles: 31.5 in females and 35.5 in male population. Anytime these patients have increased body weight, increased central adiposity, increased visceral fat, the risk for all these factors, impaired glucose tolerance, diabetes, it just goes up as the increase in the percent of the desired body weight happens. So we know this for a long time, and the Western world knew this. They have managed strategies of different programs, physical activity programs, cutting down calories, to curb the incidence of this pandemic rather. So that's why the increase in their population in terms of diabetes is much lower compared to what we are seeing in our part of the world. Do you know what is the diabetic capital of the world? What's the diabetic capital of the world? Diabetic capital of the world is actually India. So anytime they say India, that includes Pakistan many times also, because they usually talk in a bigger terms. They say India is the diabetic capital of the world. So are we, because incidence of these metabolic disorders in Pakistan is not any different than India. But since India is a bigger country, so many times organizations, instead of calling diabetic capital of the world India and Pakistan, they just name one country, which is India. But we are not any different at all. So pretty much the same slide what I said earlier. So earlier, about what is the incidence of obesity worldwide? It is a US data, 32% obese. But in Pakistan, the obesity data is above 25 to 35% based on IDF accuracy. So relatively more or less it's the same on the same lines as the US is. And the reason is we evolved from generation which ancestors which were hunters to begin with. They worked all day long to look for the food. They needed the food to survive. And then the farmers who worked hard all day, that's what our grandparents were. Most of our grandparents, most of us, they are from rural background. They used to work in farms all day long, and then in the morning or the evening had some meal just to sustain their energy, just to keep going around this. And then unfortunately we came in the picture right towards the end, where fast food, decreased physical activity, excess of food, all those contributed to this central adiposity and caused all these problems. We sit and watch TV all day, work on computers all day, and start eating snacks and foods, whatever we can get our hands on. Back in 90s, TV was big, we were slim, TV is getting slimmer, we are getting fatter. And I think this change in food, the diet industry has changed significantly. We are getting away from the organic food, we are moving towards the fast food restaurants. And even when we talk about the diet industry, the fast food industry, that itself has worsened. Burger King, one burger back in the 1950s was about 200 calories. But now the same burger is 310 calories. Coke size, more or less, numbers have gone up. Look at this French fries. Back in there, 210 calories, so the standard French fries from McDonald's. Now we are getting 610 calories when we order meat with McDonald's. So not only the food is, we are consuming a bad food, we are consuming a much high proportion of food. To give you an idea of how this impacts us, imagine if someone used 210 calories back then, and now we are using these regular size, which are 610 calories, we have excess of about 400 calories there. So to burn those calories, we need to walk 2 hours, 20 minutes each day. And then this is just one portion of the food, which is like 1/3 of our meal time for any given meal time. So imagine how much how much excess of food we are consuming, excess of bad food, excess of food with a lot of conservatives and preservatives in it, which is and not consuming the organic natural food. And that has really caused this surge of metabolic syndrome from central adiposity. Earlier we talked about those inflammatory markers, the increased fibrinogen, factor VIIA, CRP, interleukin 6, 5-1. Excuse me, let me just turn this thing off. Some I thought was off. And which causes the damage within the beta cells, causes damage within the endothelial cells, and causes and leads to extensive vasculopathy, and that's why we have much higher incidence of cardiovascular, cerebrovascular, or even peripheral vascular disease and neuropathies as well. And then there are other things with dyslipidemia. In our part of the world, there's dyslipidemia. I saw in the US also. Many times people had high cholesterol, but their HDL was very high. I have seen HDL, average person would be coming in with 50 or plus of HDL. Some people may have 60, may have 70. But in our part of the population, it's very rare to see anyone's HDL above 40 milligram per deciliter. And the LDL, for the same level of LDL, our population is at a high risk because we get that small, dense LDL particles which are more atherogenic compared to the bigger, fluffy LDL particles which European population, European cohorts have. So that's why things are pretty bad, and it's going to continue bad until we address the underlying issues there. And underlying issues in these patients have central adiposity and not visceral, not brown fat, which causes TNF-alpha, PI1, increased serum amyloid, interleukin 6, and so many other hormones. We want rather better hormones like cytokines, we should say that, like adiponectin, instead of all these deadly ones. So that is a real problem there. And now there's another, because in the past what we have done is we have talked about metabolic syndrome. Now, based on all these cytokines, all these problems that these patients have underlying, now there's a newer thing we are looking into, which is metablicity. How many of you, please raise hands, how many of you have not heard of metablicity? कितने लोग हैं जिन्होंने metablicity के बारे में नहीं सुना हुआ? I see few hands. So, okay, metablicity is, and I will urge you all to just Google metablicity. You can type in my name there and it will show up with one of the, we have a supplement about 60 pages on metablicity there. And metablicity is, what it does is, it encompasses all the features of metabolic syndrome. That's one thing. So there's a metabolic syndrome, and aside from metabolic syndrome, now in there we have lumped the cardiovascular disease in that. And then we have lumped neurodegenerative disease as well, because we believe these patients are at high risk for dementia. We believe these patients are at high risk for neurodegenerative disorders, high risk for Alzheimer's, and these patients are at high risk for aging phenomenon as well. So this is where the newer medicine is now focused at, to try to minimize the aging process in these patients. This is what all these bio industries which are involved in a big way. There's a lot of pharmaceutical industries now. These are the different there's another word with that, bio industry, like Biogen and Amgen and all those things. They are working together to come up with technology which can revert all these processes, We know that adiposity, we said, is the biggest cause. In the rest of the world, now what is going on is there is a genetic microbiome. Anyone knows what microbiomes are? Microbiotas are? Microbiomes are those clones of bacteria within your gut wall, which kind of help in many food processing, and at the same time help absorption as well, and along with many other factors. Those actually determine what goes into your system and what not goes in your system. They help to determine what will be a metabolic rate and how slow it is and how fast it is, depending on what kind of gut microbiomes you have. So yes, there's always an effort which has to be done to avoid unhealthy foods, increase your physical activity, but at the same time, a lot of work is being done now from genetic engineering, these genetic recombinant technology. All these microbiomes are they are being, that is the work which is going on. And in some centers in the US, they have already done that experimental work to clone these microbiomes and to transplant, to put those within the gut area and see how these patients, how these individuals work with a more efficient microbiota within their gut wall. So that is where medicine is going next, and that is where we all need to be thinking about as well, aside from the preventive aspect there. Prevention of diabetes, metabolic syndrome, and obesity is the biggest thing. What I care the most about, I always tell them, look at this. This was a landmark trial, diabetes prevention program trial, done there in multiple countries back there, with multiple populations involved, about 27 centers and more than 3,000 patient population. There were basically three groups. Exercise patients, these patients who are put on exercising and diet as well. And the second group was put on metformin. These were overweight patients with pre-diabetes. And the third group was on placebo. But if you look at the numbers, 58% of the whole group with lifestyle intervention, they were able to delay the onset of diabetes in these patients by within 5 years' time. There was a lesser incidence, 50% risk reduction in patients who went on lifestyle intervention. And in elderly patients, the benefit was much higher. Above 60, it was 71%. And then the second group, which was just put on metformin without any lifestyle intervention, was only 31%, and placebo was much lower. So this study, I think, is one of the landmark trials which highlights the work, the preventive work which needs to be done to deal with this deadly epidemic of diabetes, metabolic syndrome, and obesity there. This is the Finnish study, pretty much highlights the same thing. I know I'm short on time, so I'm going to just go through my second last slide. At this point, of course, in a country like Pakistan, yesterday there, Professor Javed, he mentioned that here we do not have any lab, any biological lab to create different vaccines or different work on that. So that genetic microbiomes I was talking about, this is the work of future in our country. It's being done in the rest of the world, but at least this is the very least what we can do in our part of the world. Obesity, reduce obesity, prevent obesity, go into involve different groups with your practice, around your practice, to work on the preventive aspect of medicine. So obesity and physical activity are the most preventable risk factor for diabetes and could potentially lead to more than 50% reduction in the risk for diabetes. और ये वो चीजें जिसपे पैसा नहीं लगना है, इससे पैसा बचना है. और if you tell your patient not to go to fast food for the lunch time, person saves 1,000+ rupees in his pocket. तो ये वो चीजें हैं, हम हमेशा यही होना होते हैं कि इस मुल्क में गरीब मुल्क है, पैसा नहीं है, how can we do things? ये वो चीज़ है जहाँ पे हम पैसा बचा सकते हैं. So by working on these lines, I showed you the data from diabetes prevention program. In our population, it's going to be numbers going to be even better than that. Just based on the risk prevalence in our part of the world, by at least more than 50 to 60%, we can reduce the incidence of diabetes. और जो मैंने 83% आपको सर्च दिखाने की purpose ये थी, just subtract 50% from 80%, 83%. We come down to 23%, which Europe is around 16% at this time. So this is a doable thing, can be done, should be done, and I think with the joint efforts, what we all are putting in, I think it's about time that, inshallah, I'm very optimistic with the work being done by Pakistan Society of Internal Medicine, with the work being done by Pakistan Endocrine Society to deal with this deadly situation. So my question for the audience, this is just a kind of the food for thought. Given a perfect world, what ideally should be done to reduce the twin burden of diabetes and obesity and metabolic syndrome, and what will be an ideal program in our setting? So, I mean, if we just go home and think about it, that what kind of, I have practiced, Dr. Tariq Mian is sitting here, President of Pakistan Academy of Family Physician, he has a very busy practice. Dr. Said is sitting here. So all these, they are community leaders, they are opinion leaders as well. So I think you guys, me, Javed Saab, Zaman Saab, we can all make an impact there. And the purpose, we are at this point in our career where, alhamdulillah, we are doing very well financially, but we need to make a difference. And to make a difference is not that how much we earn out of our practice. To make the difference is how many lives we have touched, how many deaths we have prevented, and that the prevention is the word here. I'm telling you, if you ask me, give me one buzzword from my talk, that is the prevention. So that is the prevention word which I'm emphasizing. So Pakistan Endocrine Society and Pakistan Society of Internal Medicine have started this diabetes prevention campaign by doing public symposia, reaching out to the schools, addressing their cafeteria food, talking to children, giving them education stuff, shopping malls. Different shopping malls are one of the best places. I just had 3 sessions in shopping malls in past month. We picked up 3 malls, Karachi Dolman Mall, we had one in Packages Mall, and third was in Islamabad, what is it? No, it was not, so they didn't give us time. But the Goldcrest Mall, there's another mall here, Goldcrest Mall, this was it. So, I mean, at every level we can make a difference. Tariq Saab, you're sitting here, I tell you, in your office, just leave the prevention stuff. Any patient who comes to you, attendants, tell the attendants, okay, this patient has diabetes, you're the family member, you're at a high risk, this is what you can do to reduce your risk by 50%. It doesn't take much effort. I do this in my practice now. I have separate printed stuff there, and this is I distribute. It takes me only a second. Sometimes even my nurse does that. So when I'm on busy days, I tell my nurse to keep them everyone. They are sitting in the waiting room. Let them read it. Corporate institutes, all these corporate institutes, we can reach out to them, and because it's a matter of educating the public, social media. There's nothing more powerful than social media. We have seen the power of social media that can be used to help curb this epidemic, and healthcare facilities, of course, that's our forte, that's where we are, should be done and has to be done, otherwise there is no way out. With this, I thank you all very much for your patience.
Very good present.